So, my name is Sarah Neville. I'm the Public Policy Editor of the Financial Times, and I'd like to welcome you all today to this important and extremely timely debate on social care. Today, to me anyway, feels a little bit like Christmas Eve. For months now, we've been awaiting the endlessly delayed white paper on social care, but tomorrow we'll finally get a chance to unwrap it. Whether it will be what any of us actually wanted seems more than a little doubtful. We've learned this week that the government will accept in principle Andrew Dilnot's central recommendation for a cap on the amount that elderly and disabled people will be expected to pay, but this will be a menu without prices. We certainly won't discover where the cap will be set, and there'll be a deafening silence on the big question of how it's all going to be paid for. I suspect some, if not all of our panellists, may also feel that Mr. Dilnot was asked the wrong question, or too narrow a question anyway. Before I hand over to our four distinguished speakers, I'd like to just touch briefly on some of the themes that have come through for me anyway in the past few months that I've been writing about this issue. No big social policy overhaul can really be divorced from the political culture in which it's been conceived. And the backdrop to Andrew Dilnot's commission was the urgent imperative, as the government saw it, to find a way of protecting elderly people from having to sell their homes to go into care. But perhaps in a way that couldn't have been predicted when we started out, the search has become overshadowed by the increasingly fraught issue of intergenerational economics in an era of massive deficit cutting. The extent to which elderly people have been, by and large, protected in the spending round at the expense of younger people, I understand, has massively complicated the discussions about how the social care overhaul will be paid for. And we heard Nick Bowles lob a grenade into the debate only this morning with his call for wealthier pensioners to be stripped of free bus passes and TV licenses. And the government's apparent sort of squeamishness and nervousness over the Dilnot recommendations also, it seems to me, points to a wider anxiety about seeming to ask people to contribute more towards their own public services. Many people, in fact, believe that they get their social care for free. So telling them in plain terms, even that they must shoulder sort of only the first 35 to 50,000 is difficult territory. It's making plain the limits of the state in a way that the government may obviously have to do more and more frequently in an era of something like permanent austerity. Anyway, I'll now hand over to our speakers. My left to right, we have with us Stephen Dorrell, the distinguished chairman of the Health Select Committee, Baroness Greengrass, vice chair of the APPG on dementia and a long-standing champion of older people. Oh, chair, I'm so sorry. Chair of the APPG. And Oliver Thomas, who brings the industry perspective as director of the UK's Bupa Care Homes. And finally, at this end, Sean Worth, who was involved in the discussions over social care at number 10. And I'd actually like to start with Sean. We'll go from my right to the left.
Thank you, right this time. Yeah. Just first of all to say on our policy exchange I've now joined, thanks very much for coming, and thanks to Bupa for helping us host the event. I just joined Policy Exchange a few weeks ago to set up a Better Public Services project. That's broadly about choice, competition, new models of delivering public services, and generally about people's appetite for reform and then how far the government can actually go with reform. And social care is no different to any other area of reform. It's largely been unreformed for, as far as I can see, since about 1948. In a serious way anyway. The big sort of challenge obviously is that it's a highly emotive subject. It deals with very, very vulnerable people. It seems to me that government after government seems not to have grasped the nettle on reform. And we've kind of heard what the government might come up with tomorrow already, because there are various leaks, stroke trails in the press. I don't know which they were, but I certainly have been working in social care policy for many years now. Back in opposition, I was the guy that wrote our social care policy. A big ambition of ours was to try and get the insurers involved in social care to a much more serious degree than they are now. Because I think we, like many people in this debate, saw the real issue being that we've got an ageing population, we've got rapidly rising treatment costs that I think annually are already at something like 2.7%. It's a system already under strain, and it can't just be a question about money being poured in from taxpayers. There has to be something more imaginative, much more innovative than that. And I think the debate we've got right now can kind of be split into two parts. One is about what does the state do, what does the state fund? And there's a question about the kind of safety net, the local authority safety net that's being set out. And it's a political decision about how much money you put into that. And that's a spending review decision. On the other side of the coin, you've got a much longer term problem, which is the degree to which people should fund care themselves, and the problem, as many politicians are seeing, certainly in their inboxes from constituents' letters, that so many people, it runs into tens of thousands now every year, are seeing all their assets, most of which are very modest, pretty much involving just their house, being completely wiped out because they fall foul of lottery, which is dementia, principally. So the big question is what to do about it. In 1999, we all know there was a Royal Commission which looked, and even then it said the system is in crisis. We need really big, bold decisions about what we need to do about it. They came out with a plan. It was kind of parked. There was some activity, but largely it was ignored for the rest of the 11 years. This government obviously came in. One of the first things it did was set up a commission on social care funding. That was done by Andrew Dilnot, and we're just over a year since publication of that, and we're all waiting what the government will say. But I think in terms of personal reflections on the whole process, I mean, I obviously can't talk in great detail about discussions that are going on behind the scenes as to the government to talk about tomorrow when it comes out. But it's obviously the big kind of elephant in the room is cost. There's a huge amount of complexity to whichever solution is decided upon. But I think after all this time, after all this sort of lack of action, lack of reform, what people will be at least looking for tomorrow, if not a detailed plan with timelines and delivery and everything else, is at least a very clear sense of direction and a very clear sense of travel, so that people can start actually planning in terms of both where the government's going to be and where the parameters are going to be, and also for their own plan. So I won't say any more than that. As one of the hosts today, I'll let the other guys have their say. But thank you very much.
Good afternoon, everybody. My name is Oliver Thomas, and I'm Bupa's director for our care homes in the UK. Bupa, probably unlike most other organisations, has an additional aspect to our care homes business. We have care homes in Australia, in New Zealand and in Spain, as well as some other businesses that look after elderly people, not only in the UK but also around the world. In the UK, we have 302 care homes from Scotland down to the south coast, and we look after 18,000 elderly people every day of the week. And we have done that for the last 16 years when we first bought the care homes business back in 1996. Andrew Dilnot, in many of his presentations when he published his report, said something I think extremely important. The fact that people are now living longer is a cause for celebration, and we should all of us hold on to that. There is a real advance in medicine that has taken place over the last several years, and the fact that people are living longer is a genuine cause for celebration. Our interest in Bupa is around residential care, just one part of the elderly care market. And we are seeing people come into residential care now who are older and much more frail. In 2003, Bupa looked after something like 4,000 residents who had dementia as a prime diagnosis. In 2011, that number had almost doubled. Just under 8,000 of the residents that we looked after had a prime diagnosis of dementia, and in the last couple of years that has increased significantly. People coming into residential care now are much older and they're much frailer. And as Sean said, paying for the cost of providing good care for elderly and increasingly frail people is the issue. Providers, charities, commentators on elderly care have been commenting now for many, many years that the sector has generally been underfunded. Andrew Dilnot and his answer around the cap is a very interesting development in terms of a system of the future, but it is only a partial answer. And it's a partial answer not only for everybody in residential care, it's a partial answer for even those that have assets. And a significant number of people that come into residential care, over 50% of the hundreds of thousands of people that are looked after in residential care, do not have those assets. They do not have homes. They do not have cash which they wish to pass on to their grandchildren. They do not have assets. And these people are paid for by local authorities under a means test, and that issue has to be addressed. Lang & Buisson's research that there is a gap between the cost of care and the true cost of providing that care of about £900 million a year and rising. And Andrew Dilnot's interesting and innovative solution does not tackle that problem. So whilst we would welcome a cap on the amount that people would pay for social care, and we would say it is genuinely a step in the right direction, it doesn't address the chronic and long-term problem of supporting the most frail and needy people who in our case come into residential care. And in our view, this has to be a matter of not only government, but political priority. This is something for all parties, not just for the government of the day. We've seen far too many white and green papers over the last 15 years. This is a political and social priority in this country, in our view, and it needs to be solved, and it needs to be solved now, before the next spending review. We cannot carry on waiting. Andrew Dilnot is interesting. Andrew Dilnot has a very neat solution, but he has a neat solution for one part of the elderly population who are coming into residential care. There are significant numbers of other people for whom that does not provide a solution, and those problems need to be addressed, and addressed now and urgently. Thank you.
I just want to look a bit overall. I think we know that we're facing, as my colleagues have just said, we're facing an enormous crisis. Lately, local authorities, short of money, have only been looking at really having any services for people critically in need. That means there's no preventative work at all. And what we're actually talking about is care, not just for people who are frail and vulnerable, and the frailty and the vulnerability of our older population, many of them, is due to recently medical success, because we've controlled a lot of the acute illnesses that used to kill people, and now we've turned many of them into chronic conditions, and so people can live with them for much longer. And that's one of the reasons why we have this crisis in care. So we don't have a system that is coping at all with what we're now facing. And you mentioned dementia. 1 in 3 of us is going to die with dementia. So we might as well face that. we're going to need it, and we're talking about something that hits the person who is ill or frail, and the entire family and all the neighbours and all the carers involved. So this is a national crisis which must be tackled. And the sad thing is that we have had all-party agreement on Dilnot. And Dilnot, I agree to some extent with what's been said, but Dilnot, to me, gave the beginning of a rational and feasible solution, because Dilnot makes it possible for all sectors to come in. So we've had all-party agreement, but we need all-sector cooperation, and the Dilnot proposals bring in the private sector, the financial sector. And without them coming in, and they won't come in unless they know the risk involved, and the Dilnot recommendations give them a risk they can calculate against. So those people who do have some means will be protected by a policy, as long as we can get people to come in and take up the policies. They haven't worked in the United States for the same reason as here, that it's impossible to calculate the risk. So if the catastrophic costs go, then there's a chance that this could work, but only if the different departments who provide care are integrated. Without that, this just won't work. We've got to bring housing in, and we've got to bring social security in. Everybody's got to come together, not just, but above all, health and social care. And unless this happens, whether we have Dilnot or some other system in the end, none of this is going to help us to meet this crisis of care. At the moment, we know that local authorities will only look after people who are critically in need. We know that of the people who are at home, people are not able to work, people are not able to have their teenage children at home, all sorts of things are going pear-shaped because of this crisis. And we really do have to get this right. Part of the problem, I think, is the way local authorities have to demonstrate annual budgeting. If I'm starting a business, I invest up front. I don't expect a return this year. Local authorities have to do a calculation on an annual basis at the moment. This makes it impossible to calculate properly. They can't do any preventative care because they can't show the savings for more than 1 year. That must change. And it's quite ludicrous to go on. At the moment, we have 7,000 old and disabled people who have lost their state support since the local authorities changed their rules because they are having to cut their expenditure. And we also know that the sub-funders at the moment, when people do go into care, in many cases, and I'm not quoting Bupa here, but in many cases, they pay over the odds to subsidise some of the people who are only getting state support for their care. To me, that's a sort of illegal tax. And it's quite unacceptable to do that to people. Let's at least be public about it. If people are going to have to do that to meet the standards, saying that's how they meet the standards, it could be said it's Robin Hood paying Peter to pay Paul. So it is something that happens, and I think we shouldn't have that sort of system being perpetuated. The answer to how we're going to pay for this is partly something that people don't really calculate, which is that we need to, and it's difficult to find MPs to agree to this, we need to change 20% of all our acute hospitals now and turn them into primary-led chronic and long-term care hospitals, which are run differently. The opportunity is with us now with localism to do that. They could partly be run by organisations like Bupa. I'm not saying they all have to be run as the NHS is run now. They could be run by the NHS, but primary care led, because this is the only way to get decent care to the sort of people we're talking about, primarily those with some sort of cognitive disorder, often linked to another illness, another disease as well. So So we really have to get the budgeting, the integration, and the care right. And the good news, of course, is that what we think we're going to hear in the progress report is that the principles of Dilnot, which are realistic, the principles will be accepted. The delay is unacceptable. We must have some sort of hope for people before 2014. We know that supported housing is going to increase, but there are questions about where the land is for this and how quickly it can be built. It's great. Extra care, heavily supported housing is one answer. People will save money by staying at home longer if they're in that sort of care. It can be done. We know we'll get a national minimum eligibility threshold. That's good because it will stop some of what I think are rather abuses of families and carers at the moment. And we know we'll get, I think, some sort of portability from if you move to be near your children. That must be made easier, but I think the local authorities who are going to fork out the money will have to agree as to how this is going to be paid beforehand or how much is going to be paid. There are still these awful issues. 800,000 older people not receiving the care they need. Huge, I've just been involved in an inquiry for the Equality and Human Rights Commission. Their human rights are being breached in many cases. Human rights for dignity, respect, human rights for family interaction, not losing all your humanity because you receive care. We know that very few, 14% of councils are able to provide care to do something for people with moderate needs. I think this is adding to the cost in the longer term. It's certainly not removing it. And we know that we need advice and information in a one-stop place for people who are desperate. You get some sort of diagnosis of dementia, and less than half do of us. But if we improve the diagnosis, which can improve quality of life, and there's nothing, you're given a diagnosis but you have no idea where to go, what to do, then that's a disaster, not a help. If there was a clear pathway of integrated care, all sectors involved, then there is some hope for the future. And my last point is that the one thing I think Andrew Dilnot said, which I agree with absolutely, it is going to be expensive to provide care. 2 billion, or nearly 2 billion, is a lot of money. But if we do it properly, we can save the NHS for the wrong sort of care for frail older people and very frail disabled people. We can actually save the NHS much more than that in a very few years. And we do have to look at this across the board, because the NHS, acute care, wonderful, the NHS is unbeatable for acute care. But for this sort of care, a hospital is not right. You go into a ward in a hospital with somebody who has dementia opposite you, you can't sleep, they can't sleep, the care is wrong, and they've probably got comorbidities anyway. They don't need that sort of care. They need to go and come straight out to a place where they receive really the sort of care they need. And we need all sectors, the care home sector, the domiciliary sector, the primary care sector, to come together with housing and with social care and local authorities. We have it there. We've got health and wellbeing boards, we've got local commissioning now. We've got an opportunity. The government must give us the opportunity to be compassionate and provide the care for the most vulnerable people in our society.
I'd like, if I may, to pick up what Sally was just saying and link it back to one of the things Sarah said in introducing this session. That's to pick up Sarah's point, that there are, each of us, she suggested on the panel, and none of my colleagues have picked it up explicitly, but it certainly does very precisely express my view, that Andrew Dilnot was asked the wrong question. A huge amount of the coverage in advance of tomorrow's statement, and I'm sure a lot of the coverage of tomorrow's statement, will focus on the extent to which the government is able to respond to the precise funding proposals that are contained in the Dilnot report. But the question that Dilnot was asked, and the question that is answered by his funding proposals, are how can we afford to pay for the current structure of social care looking out into the future? That's the question Dilnot addressed. To which I have a subsidiary, or in fact I think a primary question, which is who on earth would want to fund the current structure of social care out into the future? And that's what I mean by the wrong question. I think that was the question Sally was just addressing. If we persist in believing that in challenging ourselves to fund a local authority social service sector, separate from a local authority social housing sector, separate from an NHS primary care sector, separate from an NHS community health sector, and all of those separate from the NHS acute sector, we're asking ourselves an unanswerable question. And so that's why I don't find myself energised by the debate about where £1.7 billion is going to come from. We know, because Sir David Nicholson told us so now 3 years ago, that the challenge facing the health and care system, and it is in truth one system, the challenge facing the health and care system is not 1.7 billion, it's 20 billion looked at over a 4-year period and going on year after that as well. So answering the Dilnot question, even if you wanted to, and I've already, for all the reasons Sally was setting out, I don't feel energised by the desire to answer the Dilnot question. Even if you do answer the Dilnot question, you've answered less than 10% of the Nicholson question, which seems to me to be the much bigger question facing the health and care system. So that's not to dismiss the work Andrew Dilnot has done. I think it's a well-argued piece of work, and I have no doubt that some of the elements of that are part of the broader solution to the broader problem. But trying to plan social care separate from all the other elements of the care package does seem to me to be a fool's error. And it's why in the Select Committee we set out in our social care report a view that looked beyond social care and said that if we're going to deliver high quality care of the kind Sally was talking about, we need to see social care in the context of a joint, I don't like the word integrated, it sounds like management speak. You go into a television studio and talk about integrated care, they think you're talking Russian. What we need to be better at is thinking about the care that is delivered from the point of view of the individual family that is finding for the first time that it is unable to support and care for an elderly relative. How does that group of individuals, the relative themselves and the carers, how do they find their way to a package of support that enables the elderly person to get quality out of the additional life years that modern medicine brings? That's the challenge, but it's not a challenge just for social care. It's a challenge for the whole health and care system. It's one of the ways I like to express it is to say that if you go across into the Palace of Varieties and talk to people over the road about health, the future of the National Health Service, they think the typical patient, or those who are not actively engaged in the health debate, think the typical patient is somebody who feels substandard, goes off to see their GP, is diagnosed, is referred on for secondary care, they're cured in the hospital, and they walk out healthier to get on with the rest of their lives. That individual is thought to be a typical NHS patient. Actually, people in this room know I've just described a very small minority interest of what goes on in the health and care system. It's much more accurate to think of health and care as a system that, when the great majority of the people who use it, of the activity focus of the health and care system, when people sign up, they sign up in reality for the rest of their lives. And what we need to be doing is finding ways of delivering more joined up services that respond flexibly during the rest of that person's life, in order to ensure that they and their families have properly joined up services. And it seems to me impossible to conceive of joined up services delivered to support that family and that individual if we persist in believing that we have to have Dilnot in social care, and we have to have National Commissioning Board in the primary care system, and we have to have clinical commissioning groups in the secondary care system. And these are all separate processes going on where we hope we aspire to align them. It's why in the committee report that the Health Committee produced, we said that there needs to be a new focus on delivering joined-up commissioning as step one to the delivery of joined-up services that look across all the traditional silos. And if you want to be really depressed, and then I'll sit down, it's worth reflecting that the arguments for what we call integrated services, joined-up services, it's one of those arguments that every succeeding generation of health ministers gets to the podium, they're given the brief, and they think they're on to something new here. The depressing thing is that one of the speeches I'm fond of quoting from of a distinguished former health minister is the speech delivered by Enoch Powell in 1961, in which he made the case for properly integrated services. Every health minister since, and I have a suspicion quite a few before, have made the case for integrated services. That if we're going to deliver quality services out of the available resources for the generation that lives now and is living in the next 10 to 20 years, the rhetoric of the last 50 has urgently to be turned into something real.
Very much to our speakers. I'd like to throw it open to questions who'd like to kick off.
Thank you. Thank you. Andrew Kay from the Royal National Institute of Blind People. I'm pleased both Oliver and also Stephen picked up on this point that the Dilnot proposals don't really comprehensively deal with the question of these 800,000 older people and disabled people that Sally referred to, who probably have moderate needs, people like Mrs. MacDonald in Kensington and Chelsea, whose toileting needs were such that she did need help with her commode at night, but because of constraints on local authority resources, had that support taken away. These are the people, the 800,000, who won't actually have their needs addressed and dealt with through the Dilnot proposals. That's not, of course, suggesting the Dilnot proposals irrelevant. So I guess my question, following on from the discussion there, is how do we genuinely, in a way that doesn't just go back to the old rhetoric on choice and control and prevention, genuinely meet, here and now, the needs of those 800,000 disabled people and older people who won't be offered anything really through tomorrow's white paper if all it does is talk about Dilnot?
Well, on the particular case you mentioned, the Equality and Human Rights Commission is taking that case to Europe. The real question was that that lady had been assessed as needing one sort of care, and because of the cuts, the local authority changed what was provided, which might be shown to be against the rules, in which case her case will be upheld. My worry about that case is that the message is going to fly around to local authorities saying don't assess anybody for middle of the night toileting care because we can't afford it. And you know, there are always these consequences that you have to look for at a time of the sort of constraints we've got now, though I feel very sorry for her. But you know, I've got mixed feelings about the result because of that. And you know, that sort of thing where we're not meeting those very personal, again, personal needs which are absolutely quintessential to retain dignity and autonomy. However disabled we are, we may not be independent, but we can have autonomy. And that's what she wanted, and other people like her. They want dignity and they make the decisions. So, you know, it's one of those very tricky and very difficult decisions. But local authorities are forced into them at the moment because we don't have what Stephen was talking about, which is a long-term joined-up plan. And I don't want to have to go to the housing department if I'm 94 or whatever, then to the local social security, then to the health well-being board or the local commissioning group. I don't know anything about things like that. So we must make it simple for people with really a clear pathway of care. We must.
Yeah, it's worse than that. I agree with everything Sally said, and I also, I in particular, actually, I'd like to say I agree with the danger of going down the legally enforceable rights route, because it simply means that it gives a hugely powerful incentive to conceal need. So that route does seem to me, frankly, quite dangerous. But the other thing to be clear about here is that the extent to which what we're delivering is a system I'm fond of describing it as unaffordably bad. Because the example you quote is one example, and the equivalent example I am fond of quoting is of the elderly person who's becoming more frail, where the social service department is called and the occupational therapist goes in, and for the spending of a few £100 of devices in the home, grab rails and so forth, you can actually enable that person to live independently with some support. You don't spend that money because social services has run out of money. The elderly person has a fall and they end up 3 weeks in hospital at a cost of £10,000. So you've saved yourself £500 and you've cost yourself £10,000. That's absurd use of money of resource. But much more importantly, it's a huge deterioration in the potential quality of life of that individual. So you've delivered something, as I've said, that's unaffordably bad. And that's why I'm in favour of what I regard as the key issue here. Of course, we need to ensure that the system is adequately resourced. It will never be so generously resourced there are no choices to be made, but we want it to be adequately resourced. At the moment, I think our priority is to, bearing in mind that in the health and care system there's £120 billion of public money in that system. And the National Audit Office tells us that 30% of the non-emergency admissions to the acute sector are avoidable. Now, if you start to use that for the 30% of the resource that's available in the acute sector to pick up the pieces when the system falls over, that's effectively what the NAO is saying. Isn't it a good idea to use the money that's in the system intelligently in order to deliver better quality? Because every avoidable admission to an acute hospital is not only expensive care, it's also avoidably bad care.
I can just interject a question briefly. Do you feel that the NHS reforms will have an impact to the good, to the bad? Will they help or hinder this process of a more holistic look at what care elderly and disabled people need?
I think the short answer to that question is it's too soon to tell. There are things that in the NHS changes from us as providers and residential care providers, we would look at it and say, these are some really interesting changes to the overall system and changes that might start to engender the sorts of basic and fundamental changes to the system that Stephen described when he was talking. Whether they will work out that way, I don't know. I worked in the health service before I joined Bupa for 17 years, and I saw GP fund holding make some very dramatic changes in the very early 90s to the way in which healthcare was provided and how it impacted on acute hospitals and the balance between acute hospitals and community care. That got squashed in an instant when the major government has started to come under huge political pressure and when its majority shrank. And that dampened down a lot of very innovative and very different ways of managing a health service. It will be interesting to see whether Andrew Lansley's changes will similarly come under political pressure as we get nearer to another election. So I think there are some real issues, but we don't know yet what the impact of the NHS changes will be. There are some very positive things in there, and there are some things which clearly are causing a lot of people some genuine concerns as we get nearer to the date in which they're implemented.
I guess I'd make 2 points on that. The first of which is in response to your original question, that I think the Dilnot, Stephen talked about this being the wrong question to ask, and perhaps it wasn't his mind, but the Dilnot stuff and issues like social care integration, they are obviously completely linked, but they're two separate issues. I think that in terms of the work that he's doing, and the white paper tomorrow, you mentioned if it's all about Dilnot, it won't be that great, but actually I don't think the white paper will have anything about Dilnot. That's what most people are complaining about at the moment. I mean, that will be about the kind of groups of people that you're talking about and what can be done to better help those. Alongside that is a progress report on funding, which is where the government's got to try and set out what it believes its response can be to Dilnot. But on the question of whether the Lansley reforms will bring about the kind of integration that you're talking about, I mean, his view would obviously be yes. I mean, he's putting financial control, in his view, back in the hands of doctors rather than NHS managers, and then there will be a new system of competition for patients within that same system. So just as happens in every other service sector you can think of, the view is that when you're competing for patients or customers in other areas of the world, yes, you do want to organise services around their needs. Yes, you do want to collaborate with someone else that can provide complementary services to yours so that you get the best possible outcome for them, so that they will come back to you and not walk off and go somewhere else. And this is a big debate between what's called structural integration, where you basically force services together through creating new organisations in which to do that, or whether you look at competition as a means to drive greater innovation and greater service integration. I think most people in the current government would veer towards the competitive view. I think they believe competition is a good thing. It produces the kinds of innovation that we've just seen lacking for so many years. And the technology that's coming through now, the innovative practices, you can set up schemes through the state with dedicated budgets, and they'll do some of that, but it will be finite. It's still managed by the government. Or you can let people compete to provide that, and that drives a much greater degree of innovation. And of course, those are two separate poles, and to get to that competitive view of a completely integrated system of services, you may have to do some structural stuff on the way. But I would say yes, that Lansley would certainly argue his vision will produce that.
Well, that was just two very quick points. But we're not thinking of an individual, at least I hope we're not, an individual GP taking total responsibility. The consortia of GP practices which will be needed and are already developing on pathways to it. They will obviously have to have commissioning staff who probably come from the last structure anyway. So we're not talking about complete beginners or it won't work. But if you've got local commissioning, in spite of the difficulties of saying, NIMBY things and all sorts of differences, it's up to the government and people like you, Stephen, to insist on minimum standards which we can't go below. And some of the encouraging signs of local authorities combining forces to save a lot of money at the moment are very good. I remember just one interesting scheme, which is so obvious when you think about it. One local authority got a lot of requests which take months to get a ramp or a loo seat which is higher so that if you're disabled you can sit on it, and a stair rail really. And they realised that nobody in their right mind asks for any of those things, which are not very decorative, unless they need them. So they stopped having any assessment. They just, if you want it, here you are. They saved a fortune straight away. Well, you know, why don't we do things like that?
Which local authority was that?
I can't remember. It was while I was chairing a local authority commission, but I can't remember where it was. I've got a feeling it was somewhere like Bradford, but I maybe can't remember. No.
No one's voting in Kent,
Yes, but I don't think this was Kent. I think it was was it Hull? I think you're right, because it was, we were on the same body when we were
Same county.
yes, but just think differently. And the local, as long as we have minimum standards that can't be reduced, then I think we have an opportunity. We've got it, the law is there, the act has been passed, so we've got to make this work.
Can I take another question? Yes.
Thank you. Just more a comment than a question. When we all talk about Dilnot, we always talk about the cap. And there's so much more around Dilnot than just the cap. Of those 10 key recommendations, there are 3 that also probably come into the Law Commission as well, about an awareness campaign, a new advice strategy, integration. I've heard all sorts of talk about integration. So those are 3 key recommendations from Dilnot. It's not just about the cap. And all of those, that will increase people's awareness, will increase their ability to plan for the future. That those are all positives. So if people are actually planning ahead, then yes, the funding is important. But if you're taking that step, it's still a major step forward. So please don't think that Dilnot's just about the cap. And I'm an actuary saying that, so that's pretty bold.
Thanks very much. Anybody else like to?
Can I just comment on that, because I was sort of stood back from the last one, but I agree completely with that. And what's going to be published tomorrow, of course, is a white paper which will also take forward the important work the Law Commission's done on assessments and so forth. So there's a huge range of issues which are unrelated to the specifics of the cap and new money, where progress has been made and where progress will continue to be made, and where there's, I believe, that there's an expectation, let me put it no stronger than that, an expectation of legislation in the next session of Parliament. There was originally an expectation of legislation in this session, there's now an expectation of legislation in the next session of Parliament. So these are all issues that are being taken forward, and what the government has trailed is that there will be a progress report on funding. Well, I guess the question is A, how much progress, and B, what happens next. But all, I hope, seen in the context of a programme for real service reform. Somebody asked me this morning, where are we on reorganisation and where are we on reform? And I said, reorganisation we're doing again, we've done that before. Reform, one day we'll get around to with any luck.
Somebody else like to comment? Yes.
Hi, my name is Graham Kendall. I work with a number of organisations on health policy. I recently mapped cancer expenditure across England, cancer prevalence and cancer mortality. I was expecting to see some kind of correlation, probably a link between prevalence and mortality, maybe a bit of decrease in expenditure. I was very naive. There was absolutely no discernible link. It was quite remarkable. So my question for the panel is, if we were to do a similar exercise mapping social care expenditure, disruption to individuals' budgets and life, and social care outcomes, where do you think, what correlation, if any, do you think we would see? Then the next part of that question is, with something like cancer, there's a relatively straightforward, really key outcome, which is mortality. I think one of the challenges that I find, one of the things I struggle with the social care debate, is that it's actually very hard to articulate very clear measures for really effective social care. We kind of know it when we see it, we know it's bad when we see it, but there's a lack, at the moment, the debate is on price and cost rather than really articulating what quality can be and therefore what the vision is. So anyway, sorry, that's a bit of a combination of a question and an observation.
Start.
I think the first area of the question, I think, was what kind of correlation you get. Is that between levels of service and outcomes of social care? I think that's yeah, you're right. That is difficult to assess, but it's certainly true that there are programs going on. A telecare one is going on right now, which will try and look at the direct impact of local authorities that use telecare for elderly populations and what the outcomes of that are. We recently saw one in general medicine that seemed to show a positive impact. I think care, there will probably be a bigger impact. And you're right, I mean, one of the bigger areas of contention around this whole policy area has been the evidence for the kinds of interventions that will work. I mean, and they go from anything from the presence of a pet dog helps prevent elderly frailty, and through to home adaptations, through to intensive support in hospitals or care homes. And I think, and again, I look at the imperative now to bring in the private sector, the social enterprise sector, like the charities, to come in and just help form that evidence of what works. And as far as we can, you'll see right across public services, payments and funding trying to be linked to outcomes. That's quite difficult in an area like social care, where each individual has a very different qualitative experience of care in response to the intervention. So I don't think we'll see that much progress in terms of payment by results and all of that, but there'll certainly be innovations like personal budgets, which are going to be increasingly important, which give people at least some degree of control and choice over the kind of care that they have. So I think we're really on the cusp of a kind of revolution if we can, just as a few of the speakers have said, if we can just sort of tip it over the edge a bit. The system has been unreformed for so long. Commissioning, for example, in adult social services in local authorities, can we not have more specialised commissioning? Can it not spin out into social enterprises so that you'll start to see experts in diabetes management emerging, experts in dementia, right through to the kinds of telecare things that I've talked about. So I think the time is right for reform. Unfortunately, it's because the system is in crisis. It should have been done in 1999 when the government last did a major commission on this. But I mean, what I'm hoping to see tomorrow, and I haven't seen what the government will finally produce, but what I'm hoping to see is a real sense that there is first a recognition of the scale of the challenge, and second that we can't delay longer and put things off. We do have to have some action, and there will be all this innovation and new provision there ready and waiting.
Oliver, do you want to talk about the correlation between spending and outcomes and how they are outcomes?
Yeah. The ultimate outcome, surely, is how long people live. And actually, the average age of the population in this country has steadily increased year on year on year. And all projections would say it's going to continue to do so. And surely we should say to ourselves as a country, as a society, isn't that wonderful that people are living longer? And then I look at some of the services that we provide, and I go back to 15 years when I left the health service and joined Bupa. And if you were an elderly person in those days, you probably had about 3 options. You either stayed at home with varying packages of support, you either went into the NHS, into hospital, in actually, and I worked in some of them, some pretty poor and appalling conditions, frankly, and you went into a residential care home. You look at the number of different options that people who are old now have, and they are huge. And there's everything from telecare and telehealth through to assisted living and care villages and various other models and models that did not exist 15 years ago. We have moved on hugely as a society, and our systems have actually changed. And the ultimate measure of outcome in terms of the average age that people now live to is significantly higher than it was, because in part, I would argue, of all of those advances. My prime concern is for the frail and elderly and needy people, and for those services that are provided, largely by the independent sector, but not exclusively, the cost of them and the local authorities that pay for them, who are under extreme financial pressure at the moment. And I take it from both the public sector and from the private sector, there is a direct link between what is paid for and the quality of care that is provided. And that link needs to be recognised and understood by the government, and they need to understand that and make some changes in the future.
I think we've got time for one more question, actually.
It's kind of a question really. Oliver mentioned at the very beginning achieving standards you presented to the teacher support network charity. Oliver, you mentioned at the beginning how many hundreds of thousands of people fell outside the kind of net of having any resources that would be able to fund their own or contribute to their own care in the longer term. And that's what I'm left wondering about really, because if you have some assets, if you have some resource, you will have some choice at some level or other. And yes, clearly, integration, whatever word we choose to use, about streamlining and making sensible choices and decisions rather than bureaucratic policies of assessment, and which, it's cheaper just to deliver basic things to people. All these things need to happen. But what happens to the people who fall outside that? They're increasingly going to grow. People who can't afford their own homes, people who won't have a home, don't have a home to sell. What happens to these people is what I'm interested in, because it seems to me that that is a funding challenge. Regardless, it is just a huge money challenge. So how does that get addressed? If it isn't through taxation, what else are we encouraging people to think about or do? Because that's a big gap in social policy in terms of articulating to people, quite honestly, actually, you may not have that choice. How do families, people plan for that for the future? Are we envisaging a world where people will just be then left at home?
How do people face up?
Is exactly my point, and I think part of the point that Stephen was making about changing the overall system, and it's not just about care. But you're absolutely right, and the point we are making is that there are a significant group. We would estimate probably in residential care over 50% of the population of people who are in care homes, the people that we look after in our group homes, who by definition do not have any assets at all. They do not have a house. They do not have a cash to give their grandchildren, and actually their choice is limited as to where they go and the support services that they have. That is our argument, and that is what, in our view, the government needs to address the matter of urgency. They cannot wait 3 or 4 years until the Dilnot Commission comes into being and white papers go through. Those people need to be looked after now.
Well, I agree, but what I don't agree with is the implication that the only way we can solve the problem is by going over the road to the Treasury and they'll sign a cheque. The issue we've got, and the thing that shapes the debate, is a budget deficit which has to be brought under control. And as I quite often say, if the Ministry of Justice runs out of money, then they go and see the Treasury, they get another 200 million, it's lost in the reserve and nobody notices. If the Health Service runs out of money and they get a cheque for 200 million, it's gone by elevensies. This is the resource requirement in the Health Service to address some of these challenges is an issue of health policy for all the reasons you identify. If we don't get it right, there will be need that won't be met. But equally, it's an issue of economic policy, because if we don't get it right, we find ourselves with a spending overrun that has economic consequences as well as social policy consequences, which is why in the Health Committee we go on endlessly about what we call the Nicholson Challenge, and why I described it again this morning. The Nicholson, I referred to the 15 to 20 billion, which is the number everybody recognises in the health service. Actually, I don't personally like that formulation because it implies 15 to 20 billion pounds of, and then it leaves in the air exactly what it is. It's not cuts because the budget, the government's committed to a modest real terms improvement in the budget. What it is a requirement within the health service to meet rising demand, for all the reasons you identify, rising demand at the rate of, roughly speaking, 4% per annum, has done since 1948. Demand on all these services grown by 4% per annum in this country since 1948, and in every other developed country. So we should assume it'll go on growing by 4% per annum, but the real terms growth in the budget has come to an end, at least for the moment. Not for all time, but for the moment it's come to an end. Which means the only way we can meet those demands, right, answer your question, is by using resources more efficiently around the system as a whole by 4% per annum. Now, that comes right back to the question actually at the back. What does good look like? There are so many examples in the system of how we use resources badly at the moment. And if we use them better, I don't know, I don't personally believe it is impossible to deliver 4% efficiency gain 4 years running, which is what we have to deliver if we're going to meet demand within the resources available. I'm not persuaded that we can simply trip across to the Treasury and get more money, which means we have to deliver 4% efficiency gain 4 years running. Which is why we've got to tackle the acute sector, why we've got to tackle the silos, why we've got to refashion care. And that's all much, much more difficult, more controversial, more challenging than changing the bureaucratic structure, which is what we go on doing.
Do you want to make a final word on it?
I agree with quite a lot of what Stephen has just said, but I do think that if we did our sums properly, we would find that if you really look at the unnecessary or incorrect expenditure of the NHS on a whole lot of the people we're talking about, we would save quite a lot of money. So what I said about annual budgeting and the way local authorities use their money and the way that could be changed fairly quickly is a way forward. We can't abandon all these people. We have a crisis now. We have something called a welfare state, which still exists. So if we just leave things as they are now, we're going to have huge, unthought about bills to pay. So we have to do something now. We can't actually wait for the spending review. There is a crisis now. And, we've got to get something done. And my view is within 2 years or 3 years, the NHS would find it was spending less. And the sort of care we're talking about, if it's not joined up or integrated or whatever you call it, Stephen, is much more expensive than it needs to be. Putting someone even into a care home unnecessarily, if they could stay at home, is very expensive. Take one I know, a charity home in central London. Well, I would call it not quite here, it's a little bit out, St John's Wood, Kilburn area. It was a very nice charitable home for people mostly with dementia, very expensive. They went broke, they had to close the home down. The cost was £1,250 a week. So we demand high standards. So we have to do something about this or reduce it. We don't like it if the standard goes down. So we have to change the way we look at services. We must pull them together. We must keep people at home for longer, which is what they want. But you have to then swap the services around so that those domiciliary services are increased. They go into your home later because they've stayed at home for longer, so mum can be in the workforce for longer. There are all sorts of things you need to take into account in the calculation. The kids will come home from school, or the teenagers, they won't necessarily just go away. You'll have impact on families. And really, in a sense, if we don't do this, we're letting ourselves down as well as these very vulnerable people. We've got to do something now. We can't wait till 2015 or 2016.
On that note, sadly, I'm going to have to bring this discussion to a close. It's been absolutely fascinating, and we'll see what tomorrow brings. But in the meantime, I'd like to thank all our speakers.